Welcome everybody to the September 14th meeting of the LA City Health Commission. We currently do not have a quorum, so we'll start with public comment first, go into the commission presentations, and then we'll do other business as the individuals who are slightly tardy join us a little bit later. Is there any public comment in the waiting room?
Yes, there is.
Could you introduce themselves, please?
Good evening, speaker. You're on the line with the Los Angeles City Health Commission. Please state your name and the agenda item you are speaking on. You have 2 minutes to speak on a public comment or agenda item.
We're not hearing anything from the public.
Yeah, they've been led into the room.
Okay. Thank you, Marvin.
We can't hear you if you're trying to speak. Let's proceed to the next person then. Sarah?
Marvin, if you want to remind the speakers that they need to press pound again when they're prompted so they can, maybe that's, like, let's see, what else do they need to do?
Did you press?
They're currently unmuted.
Okay.
But if you could press pound before speaking, perhaps we can hear you then. Yes, unfortunately, we can't hear anything at the moment.
Can we have them dial back in and go to the next speaker? The next...
Yeah.
Yes. Good evening, speaker. You are on the line with the Los Angeles City Health Commission. Please state your name and the agenda item you are speaking on. You have 2 minutes to speak on a public comment or agenda item.
Hi, good evening. I'm Lauren Natoli from the AIDS Healthcare Foundation. Can you hear me?
Yes, we can. Thank you.
Wonderful. First of all, this is a general public comment. First of all, I want to thank you for reconvening the past few months and for the interesting and relevant topics that you've consistently been bringing forward. Subjects like telecommuting and examining health disparities show that LA is ready to grow in the face of the current universal challenges, so thank you. My comment to you today is that you examine housing from a perspective of public health. During the COVID-19 pandemic, people cannot socially distance or shelter in place when they do not have safe, hygienic places to stay. Housing is a top health priority, and other priorities like medication or hand washing will often fall to the wayside when housing is not met as a need. So Los Angeles County currently needs over 500,000 more affordable housing units to meet the current demand, and that's before we've seen the impact of COVID-19. So I just want to ask that this is kind of on your radar and that you look at this in the future. Thank you.
Thank you for coming today. We truly appreciate your comments. Is there anybody, Lauren, is there anybody else in the virtual waiting room?
There is not, no.
Did the other caller who was there come back or no?
They are still in the call, but they have not been able to speak. But we just put them into the waiting room again.
Okay, well, caller, can you try again by hitting pound and see if we can hear your public comment? We appreciate you coming today. I guess not. Seeing that we can't, Is there anybody from the neighborhood council who has called in? Seeing
There's
none,
no one in the council.
thank you. Seeing none, Rita, can we do a roll call at this point?
Yes. Commission President Mandel,
Present?
Commission First Vice President Grimmig,
Present.
Commissioner Second Vice President OOC is absent today. Commissioner Avila has not been able to join us yet. Commissioner Estradas has let us know that she would not be able to make it. Commissioner Hisarick is not with us. Commissioner Cato,
Present.
Commissioner Kalfani has not joined us yet either. Commissioner Lemos is still not with us as either. Commissioner Shannon,
Goodbye.
Present. Here.
Commissioner Sidota,
Present.
and Commissioner Whittington has not joined us yet either. We do not have a quorum.
Thank you, Clerk. So we'll move on to agenda item number 1, a presentation from the Chief Information Officer of the Office of the Mayor, Amanda Daflos. She is going to discuss how the city obtains crucial health information, the type of information that we're collecting, and to discuss how we could help and work with the mayor's office to disseminate that information to healthcare workers within the city of Los Angeles. Thank you, CIO Daflos. We truly appreciate you coming, especially that we know that you're on your vacation today, but we appreciate you presenting to us. Thank you.
Sure. Well, commissioners, thank you very much for the invitation, and thank you very much for all the work that you all have been doing. It's always a pleasure to join any of our commissioners and be able to talk about the work certainly that the city is doing. I know that, just for the record, my name is Amanda Daflos. I'm Mayor Garcetti's Chief Innovation Officer, and in that role, I oversee sort of a broad portfolio of topics and teams, and one of those things has come to be our response when it comes to data and research and innovation around COVID-19. So that's the role that, at least at the moment, that I've been playing, and I serve the mayor in terms of helping support his efforts around COVID-19 and then across the city. What I thought I could do today is I can certainly show you some of the content, but I do want to acknowledge that I understand that it was important to sort of talk about how we're partnering with the county, including Dr. Gunhauser, who I know is here today and will be making a presentation shortly. But one of the important parts of the work that we've been doing is really liaising with the county. And so I also serve as one of the mayor's primary liaisons for the county and for our county partnership. The reason why this is important is because the county plays the lead, of course, as the public health agency for the entire region when it comes to the response. And for the mayor and for the city, I again serve as a liaison to be sure that the county has a point of contact, and then vice versa, we also have a point of contact. I can be sure that we're just tracking with all the efforts that the county needs support on, and of course, vice versa. As you all know, the City of Los Angeles has the County Public Health Department serves as our public health department. Places like Long Beach and Pasadena, as cities, they have their own health departments, whereas Los Angeles, importantly, is in a contract relationship with public health. So that just becomes even more important in a pandemic. I wanted to also note that the work that my office is doing is sort of multi-part, but one important thing that we do is we produce a report daily that's released to the public. And I'm going to show you kind of where all that is here in a minute, but that report is released to the public. And the reason we've been releasing it to the public now for, I think, about 182 days effectively, is to be sure that we're communicating clearly with the public around the key trends and key data, which is also reported by the county. So I'll take you through some of that in a minute, but just wanted to acknowledge that that's one really important thing that my office does. And we've been studying COVID since January. Importantly, we are not medical practitioners. We are data experts, we are design experts, we are project management experts, but none of us are medical experts. We are data people. And so we're presenting this information, importantly, from the point of view of people who've been studying a disease deeply, but even more importantly, people who are data leads and data experts. The other thing that we've produced is a dashboard, which is also publicly available, and that dashboard tracks information for the city. So whereas a lot of the content that's tracked is county-wide, then broken down into city information, and we've produced a dashboard, which is also publicly available, that I'll show you, that residents and commissioners and everybody across the city can easily access to get a handle on the information related to COVID, but also the information related to our economy and several other key areas that we know are emerging and continuing to be even more important from a social point of view. And then there are a variety of other tools that we've created, including a threat level indicator that helps people understand the level of COVID risk in the community. Again, publicly available online, and I'll be able to show you that as well. So before I kind of jump in and perhaps start presenting a presentation, I just wanted to see if there were any questions or anything that you wanted me to touch on before I start sharing my screen.
Any commissioners have a question at this point, or would you rather wait until after the presentation? See no questions at this point. Thank you, Amanda. Why don't you proceed?
Great, thanks. So I'm going to go ahead and just share my screen. Hopefully you can be able to see that. Are you able to see that?
Yes.
Great. Alrighty, well, on the mayor's website, which you can find, I'm going to start by showing you where you can find this information. So on the mayor's website, which is lamayor.org, the place where we house this information is it's called Update on Coronavirus. So in the top right-hand corner, yellow. And then my section, or all the information that I'll show you today, is in this FAQ orders data section. And down here at the bottom is data. And so the first you'll see is the dashboard that I mentioned. And so this dashboard is updated real time. And the reason why we did this is, as I mentioned, we wanted people to be able to see not just the county information, but importantly, also the city information. And so we show three different dimensions here on the top. One is health and wellness. And so this is a variety of key dimensions related to cases and deaths and hospitalizations. Three of the top things that you all know have emerged as really important things to track, as well as the positive test rate, cumulative. And I can dig in, as I'm sure Dr. Gunhauser will, to all those things here in a moment. We also talk about helping residents. The city has launched a wide variety of programs, everything from meal programs to renter protection programs to housing programs to actual and what's called an Angelino card. We've tried really hard to keep all of these things updated so people can get a sense at a high level of the things that the city is doing to help them either remain in their homes or access food in these troubled times. And then when it comes to city services, there's a variety of things that we track, including 311 calls and some other city services type things. For a deeper dive, you can scroll down and see a whole wide variety of data around this top row: cases, deaths, and then hospitalizations across the city and then the county. And you can see some change data as well. We track, over the last several days what has changed. And then importantly, because this is emerging or has emerged over the last 6 months as a growing area of concern for all of us, is the percent of deaths and then cases by ethnicity. And so we track that here on this dashboard in an easy to view way. Then if you scroll down to the bottom, and actually, you know, I want to note that we launched this dashboard about a month ago. I arranged for some pro bono support from two vendors, Tableau and a firm called Solemn. It took them, due that it was pro bono, it took us about 6 weeks to get the whole thing done. But what I really wanted was a dashboard that the public could view. And so we were able to synthesize that in a really easy way. But what we've been doing since really March is these much deeper data decks, as we call them fondly. But these are very extensive documents that we produce every single day. And we produce them thanks to our partnership with the county, as well as information that's made available by the World Health Organization, State of California, and Johns Hopkins University. Those are three of our primary sources. And so you can scroll down and see these. They're posted every single evening. You can see every single month. I think we began posting them in April, but I've been creating them, frankly, since the very beginning of March. So I'll show you today's. It's about to be posted, actually. So I'll show you today's, just so that you can see what we do. Every day we produce the same data, but typically on Monday, Tuesday, Thursday, Friday, these documents are what I call the condensed version. And then on Wednesdays, they're quite a bit longer. And the reason why they're longer is because there are some things that are only, they only change about once a week, or it's really only worth measuring to see change once a week. And so we do all that now on Wednesdays. Wednesday's document, to give you a sense, is about 100 pages. The document on the other days is about 50 to 60 pages. But you see that same content around cases and data and testing and hospitalizations every day of the week. It's just that you see things like headlines, or you see things like domestic violence data. There's just some things that we only do one time. So today, is, for anyone that's been following, is day 186 of the city's coordinated response. Last week marked 6 months. This is just a snapshot of what we produce. And of course, this data, it's numbers, but what it means is, and what it helps us understand is really how COVID is evolving in Los Angeles. And that's something for those of us like Dr. Gunhauser and the county, we're sort of following these trends on a very, very deep level so that we can be able to understand how we moderate things. I won't take you through everything. It's a really long document, but I wanted to be sure I let you know where it was on the website so that you could go look at it after. But the few things I wanted to touch on are this screenshot, because we put this in every day. As you all know, the state is driving, sort of the way that the government is coordinating is that the state, so Governor Newsom and California Department of Public Health are making a wide variety of metrics and indicators that counties have to perform to. And then counties have the option, counties must perform to those levels, but they have the option to be more restrictive. And then cities have the option, in our case in LA, to be even more restrictive than the county. To date, we've all tried to work together. This has been really important to Mayor Garcetti, that we all work together, because given the nature of COVID, if the city does something slightly different, it doesn't really necessarily make all the difference. What matters the most is that regionally and as a county, we work together. And that's something that Mayor Garcetti, Dr. Ferrer, the city council have been really trying to push forward. I show you this because at the state level, Los Angeles is measured every 2 weeks now. This is a new framework that the state rolled out on August 31st. But really in the end, what it says is that every 2 weeks, all counties across the state will be measured on Tuesdays. And they will be measured on two indicators. One is the number of cases that we have per 100,000 people, with some adjustments for the rate of testing that we're doing. And then also the second indicator, which is here on the bottom row, is positivity rate. So what is our positivity rate over that period of time amongst people who've been tested? There's 4 levels. You can see those down here. Widespread, and you have to meet a case requirement and a positivity requirement. And then it gets down to the yellow level, which is the least restrictive, and it means you have the least amount of COVID. As a county, the last measurement was taken last Tuesday, and we remain at widespread or purple. We have evolved quite a bit, particularly over the last month. And you see that based on positivity rate now being down to 4.3%. And we were actually, quite frankly, closer to 10% when we look back to months like the end of July. So we have evolved that significantly. And we've also evolved the case rate, which is right here. We are, when you do just the math, we're at 11, we're at a score of 11. When we adjust for the amount of testing that we're doing here in Los Angeles, because we are doing, if not more than any other county, certainly as much as any other county, we get sort of a credit for that amount of testing, and so we're adjusted down to 9.6. This measurement will be taken again on the 22nd of September, and you know, if we do reach this case rate of between 4 and 7, then we will be moved down red. One thing that's important to flag is that they take the number that you're performing worse on, not better. So you're probably wondering why at 4.3% we're not in actually the moderate level. It's because our case rate is still so high, and that means community transmission is still really high here. So we remain in purple. And if we can get both those numbers down, then, you know, with fingers crossed, we'll move down to the red. What that ultimately means is that we remain in a place where our restrictions are in place, but we can put some other reopenings in place, as you've seen the county do, particularly over the last. There's a wide number of things that stand behind this, but I also wanted to note that these are the general things that we as a mayor's office track for the city. So cases on the daily, so we do a 7-day average. Deaths, we do a 7-day average. Positivity rate, which is cumulative, new hospitalizations, and then a series of things around hospital capacity. And then we also look at the city crime and city unemployment insurance claims. So that gives you a snapshot of sort of the detail, and there's a lot of detail that stands behind all of that, but that's the high level of what we look at. And then this is another high level snapshot. I do want to note that we look globally. So it's really important that we look every day at where we're performing as a state. So we look at California and we rank where California is versus any other state in cases and deaths. We look at where we stand as a county in counties that are 100,000 people or more. Today, for example, we stand, we are a number 112 out of the 584 counties that have 100,000 people or more. When it comes to cases, and when it comes to death, you see down here at the bottom, we're number 139 out of 584. So that just gives us a perspective on counties that have 100,000 people or more, just to know kind of where we stand, if we're better or worse, which is, I think, just really important for us to know when we think about kind of the pile that we sit in amongst counties. As I noted, there's quite a bit of detail, so I won't really take you through all this unless you'd like me to, but I recognize time is probably of the essence, and I want to be mindful of your other presenters. But there is, you know, quite a bit of detail, and I will share the link in the chat for all of you. But that just gives you a snapshot of the sort of the different dimensions that we're looking at around cases and deaths at the county level. We look at the case and death demographics at the county level. We look at the race detail around deaths, cases by age, deaths by age, and then a whole variety of other things. I also wanted to note that we use a variety of tools. I think that was a question for me, is what tools are you using? I wanted to just provide really quickly a sample, which is the World Health Organization. They have a variety of dashboards that they use. This is a snapshot of one of the ones that we use. We use this mainly as sort of a sense check on a lot of the work that we're doing. And then, of course, Johns Hopkins, and you're probably all very familiar with Johns Hopkins. Johns Hopkins is another tool that we use. New York Times has produced a number of really great tools, as has LA Times. So there's a variety of those kinds of things that we use. I also want to note that we have a team that's pulling research from all the medical journals, and that really helps us sort of stay informed on, again, as non-medical practitioners, but people who are following trends for the city. we look at it in a trends point of view, where we're able to pull the most important medical reports and review those and sort of have a point of view. And then of course daily we meet with the county to be sure that everything that we're producing is coordinated and aligns with everything that the county is producing, which we think is really important, again, for the region to have just a shared message. So I will pause there. I'm happy to dig into any one of the 70 pages that we produce, but I did want to just, again, be mindful of time and provide you with the link to where the data can be found.
Well, thank you. Thank you for your presentation, and thank you for the wonderful website that has been developed. It really helps us as well as the people in the city of Los Angeles to get data. Clearly, that's different from what was early on, that there was a lot of unknowns. The question that I would have is, when we adjust data, we know that unfortunately nursing homes and assisted living facilities, as well as prisons, had individuals who were more rapidly exposed and infected, who then ended up being hospitalized. And they'll have a major impact, as their percentage was quite large, on the total numbers. So just as a question, why nobody has decided to adjust out those numbers, because to truly get an understanding of the infectivity in the community that's affecting day-to-day life or our small businesses, it's really not going to be the same population as be affected, say, in a nursing home or assisted living.
That's a great question. Thank you for bringing that up. One of the things I'll note is that that is happening, actually. So at the state level, that dashboard that I showed you, the state is taking out, before they do the case rate data, they are taking out jails, and I believe they're taking out some other forms of shared living. And so they make that adjustment, and then they do the case rate. And then the county also, Dr. Ferrer and her team, they do press briefings, generally on Mondays and Wednesdays, and Dr. Gunhauser can probably speak to that certainly better than I can. But in those press briefings, they speak to a few really important dimensions, including nursing homes, jails, and then other forms of assisted or collective living, and then also homeless, the people experiencing homelessness. So those three numbers are broken out. And I should note that we break those out in our document as well. So depending upon where you're looking, there's so many different ways people are measuring things like case rate and positivity rate. You have the 7-day average, the 3-day, I mean, there's lots of different dimensions. But I think in the places where we're being, say, measured by the state, those adjustments are being made.
And the second question that I would have is in regards to hospitalizations and ICU beds, is how are you given those numbers? How do they come to you on a daily basis?
There's two sources for hospitalization data. One that is a state census that occurs, and we can share that with you. I believe it's public at the state level. And then there's a source that we also use through the county, that the county uses, which I believe is also a public census. So there's two different censuses that are going on, again, one by the state and then one by the county. In both cases, these are census items that have been going on, as I understand it, for a long time. The state one pivoted a little bit in April, and then the county one, called HAVBED, which you all are probably familiar with, is the other one that we use locally. You've probably seen LA Times, you've probably seen any of the state papers. They use generally one of those two sources, as do we, and also our county colleagues who produce their data dashboards as well.
And do we know that those are accurate numbers?
Yeah, it's a good question. I mean, I will note, I'll be looking forward to what Dr. Gunhauser has to say on that as well. I mean, from my perspective, we sort of, I'll just say that we have a number of folks that are that we hear from regularly, who are letting us know what things are like on the ground in hospitals. And as far as we can see, we don't necessarily see that there have been any reported errors. I will say they're imperfect. That's what I will say. They're imperfect, and I think since the beginning of reporting, we're aware that just the way that the fluctuations happen in a hospital, there's people who are known COVID, there's people who are suspected COVID, there's people who are sort of waiting to be admitted. We do see some of those breakdowns, but we only, in our case, only take people who are known COVID. We don't make any guesses about the other.
Right. We would think that just going forward, if we can learn from this a little tiny bit, it might be nice for the city actually to have communication with all the hospitals so that you're given directly the updated data on a daily basis in both hospitalization, ICU availability, and then also surge capacity in order to allow the mayor's office to appropriate plan and to work with the county to get the information. Because the city hospital beds are a little bit different than the county, though there's a communication between the two. The city numbers are a little bit different.
Yeah, absolutely. And I've learned an inordinate amount about how all this works, and the 70 hospitals that are considered ER hospitals versus the 90 that we have in the region. And each one is slightly different. Some report into both, some do not. And I will note that, if we do reach a place where the city has a Department of Public Health, I think it'll be this experience will be a learning opportunity for anyone that's been working in this space. If you'd asked me a year ago if I imagined that this would be what I would be doing, I would have, surely none of us would have expected to be here. But surely I would not have expected to have become as intimately familiar with every aspect of reporting. And I will note that while this document looks like it's easy to produce, it takes a team of 7 or 8 people a number of hours to do this every day, and what that tells you is that certainly we're taking a level of perfection to this because it's public information and it's really important, but also because every day things change, and every day we have to review the sources and make sure things are correct, and speak with a wide variety of people across the city and the county to be sure that that we're getting the right information. So I say the hours only to tell you the level of effort that goes into that piece of work.
Thank you. We truly appreciate that. Commissioner Kato, you have a question.
I had one too.
Yes, thank you, Amanda, for taking time out for the presentation. And I'm looking at the website as you were speaking, and very detailed. One of the things for this data to be used like more in a preventative way, you said that this is a city breakdown. Is there any way to break it down even further to council districts, the 15 council districts, or is that?
That's a great question. The county, actually, I'll post the county, now that I'm sure I'll find it and post it in the chat. The county breaks down, they have a number of dashboards, and so I'll share this with you as well. There's one area on their dashboard where they break it down across the county by city, and I find that to be very, very helpful. And then they also break it down, and I believe it's published by supervisor district, and that's also very helpful. We've broken it down over time by council, but it's a bit of an imperfect science, just because we run a very large testing operation, as you likely know, in concert with the county, and so we have ways of looking at things like positivity rate by zip code. We're able to look at some of those kinds of things, but that's not something that we publish, largely because we just haven't published it. It's really the only reason.
Okay, thank you very much.
I have a question.
To the question.
I'm trying to find it. Can you hear me? Okay. On the hospitalizations, first of all, pardon me for being late. You may have covered this at the beginning. But on the hospitalizations, is that people from the city of Los Angeles, no matter where they're hospitalized, or people in hospitals within the city of Los Angeles, wherever they come from?
It's the latter. It's people that are in any hospital, with any reporting hospital, that any reporting hospital within the city, and I believe it's regardless of their where they're from.
Okay, I just kind of get a sense of what it is. I think the gentleman from the county can clarify it, but I think the hospitalizations are in part coming from data that the Department of Emergency Medical Services Group, in terms of some of the admissions that they have to hospitals. I believe that's the source of some of the data about hospitalizations, I think.
Yes.
Okay, thank you.
Of course.
Are there any other commissioners with a question? Seeing none, thank you, Amanda. We truly appreciate you coming for your presentation, for the data and all the work you do for the city of Los Angeles. We truly appreciate your dedication to keeping people in Los Angeles safe. And we really believe that you do have a positive impact, so we appreciate it. Thank you very much.
Thank you all, and thank you for your service to the city. We really appreciate everything that you do in your spare time as commissioners. We recognize you all are very busy people. So thank you for the same contribution and of course for the invitation. I really appreciate it.
Thank you.
I know that I have posted, I posted the 2 dashboards that have information from the county. And again, Dr. Gunhauser can speak much better than I can to their own tools, but these are just 2 of the tools that we collaborate with the county on. We spent a lot of time with the folks who have built these and designed them and are using the data to input. So I wanted to share at least these 2 so that you could look at them from the county websites.
Thank you. We appreciate that. Moving on, the next presentation will be from Dr. Jeffrey Gunshauser, who's a MD, MPH, and Chief Medical Officer and Director of the Bureau of Disease Control for the LA County Department of Public Health. Dr. Gunshauser, we truly appreciate you coming today.
We can't hear you.
Sorry about that. Can you hear me okay now? All right. Thank you very much, Dr. Mandel. That was a very impressive presentation. I hadn't had a chance to really be aware or see some of the metrics you put together, and that is really fantastic. I'm going to go back and look more at that myself. As you said, Dr. Mandel, I run one of the 4 bureaus here in the Department of Public Health. I oversee the Disease Control Bureau, which is all the communicable disease work in the county. And in response to the pandemic, I run the operations section in our incident command system. So I oversee all of the response efforts, the outbreak investigations, the data collection, and all that. So it's a real pleasure for me to speak to the commission. Again, I do thank you all for your service. It's a real pleasure. I think it's been a few years since I've had a chance to speak with this group. So I thank you all for including me. Let's see, I'm going to take over my screen here and present some slides. Let's see if I can get this to, hold on, I'm sorry. Here we go, that'll do it. Okay, so hopefully you can see my first slide. And I'm just going to be talking, I'm going to go over some data that overlaps a little bit with what Amanda covered, but to try to share some of my insights on where we've been with the pandemic and what's going on currently and what we're doing to address it. So here's a brief outline of the things I'm going to cover. I'm just going to go over some of the key numbers and some of the key trends to make sure that, at least from my perspective, how I view things, I'll share these with you. Amanda has already nicely covered the state's tiered framework, which was rolled out a couple of weeks ago. And then I'll talk a little about how to bucket, what are our buckets for our main strategies and what we're doing in these areas. A few specific questions were asked with me, and I'll try to address some of those. And then we'll open it up to your questions as we go along. And if you have a question as I go, I assume there's a way to sort of raise your hand or let me know. I'd be glad to, if you have a question as I'm going along. Let's see, as the numbers, I think you're all very familiar with these. These are rather extraordinary. None of us have ever seen anything like this. I think I just read today that the world experienced 300,000 new cases in one day. So it's just numbers off the chart. Been involved with a lot of communicable disease efforts over my career as a public health physician and never seen anything quite like this. So you're familiar with these. Of course, these days numbers are a few days old. So that, you know, these have been updated. US for over 6.5 billion cases, almost 195,000 deaths. California over 760,000 cases and over 14,000 deaths. And in LA, at least in our jurisdiction, we have over 240,000 cases and 5,854 souls have lost their lives that we've been able to count so far. So it's just extraordinary. I'm just going to go over a few of the charts. This is just the case chart, which most of you have seen or are familiar with. This does show cases beginning in the middle of April on the left side, extending up to about a week ago. And as you can see, we were running about 1,000 cases per day here through most of April. And then by the end of May, it kicked up to about 1,500 through the month of June here after Memorial Day. And then after the July 4th holiday, it really took off and we hit this peak up here well over 3,000 cases towards the end of July. And then we closed a lot of things down and we just had this remarkable steady progression since then. So we won't really know the impact of the Labor Day holiday on our cases for at least another week or so. As you know, we've had a lot of very bad air quality and very hot weather. So we think that's affected people going for testing. So while we continue to see a decline, we think a lot of that might be because people just aren't going to get tested. So we'll have to see in another week or so how these trends play out. This is one of the hospitalization charts. I don't know if you've seen this one. It's rather detailed. You can see there was a change here in the methodology where it was split from just cases, but also you know, what's been confirmed and what's suspected, et cetera. But we largely follow the blue line here, which is the number of hospitalized cases that are confirmed. And as you can see, there's been remarkable changes over time. We were up to over 2,200 cases for about 6 days in a row here in the middle of July, 2,200 hospitalizations. This is 92 hospitals that we're tracking through the system. And then we've had a steady decline. Every week or every day I look at this, and I'm sure you do the same thing to see and hope that these trends continue in the right direction. In the last 2 days, we've actually had less than 800 hospitalizations reported in LA County. So that's a remarkable downward trend. This slide here shows the 7-day average of the daily number of deaths. It's similar to the hospitalization chart and having 2 peaks here. As you can see, the higher peak was in early May, right about here, where we had over 45 deaths per day in LA County. That dropped down and almost reached up to the same peak. And now more recently, we're down to about 30 deaths per day, perhaps a little bit less than that, depending upon exactly how you look at it. So that's definitely moving in the right direction, as you will. This is one of the charts that I think is very informative. This shows 2 numbers related to deaths since the middle of June, so it doesn't go back quite as far as the previous chart. But the top is the total number of deaths that we've experienced in LA County, and the lower line is the number of deaths in skilled nursing facilities. So what this slide shows is that during the overall resurgence of cases here that happened in the month of July, including cases, hospitalizations, and deaths, the death rate really did not go up among people who were in the skilled nursing facilities. The downward trend that had started a couple of months ago continued. So that did show that what we were doing there was saving lives and continued to save lives, even as the county had a massive resurgence in the month of July. So I think that's a good news story. It does show that measures, when put into practice, do work. And we've continued to have this decrease even into the recent weeks. Another key indicator we track is the positivity rate, which was mentioned earlier. This, of course, is the percentage of tests that are positive. And we consider this, as mentioned earlier, as a good proxy for the level of community transmission. So in other words, the greater the level of community transmission and the higher the positivity rate. And this chart bears out that interpretation. So, you know, early on when testing was limited back there in April, we of course are really only testing high risk people, and those individuals of course would have a prior probability that's higher. So we are experiencing positivity rates here back in April that were 15%, but obviously we were having a a lot more disease spread here early. And then you can see that the positivity rate here fell down under 6%, resurged up to nearly 10% as mentioned in mid-July or late July. And then since then, it's fallen back down under 5%. So really, this really does show the effects of, the safer at home order, people going back into homes, reducing transmission. And then when we open things up, this means that transmission is occurring at a higher rate. And of course, more recently, it's been lower. I'm not going to show a lot of data, but I think you're well aware. And again, this was highlighted in some of Amanda's data as well. But COVID-19 has had a disproportionate impact on our persons and communities of color. And this slide shows that the case rates are markedly higher in individuals who are Black, American Indian, Alaska Native, Latinx, or Native Hawaiian or other Pacific Islander compared to white. So I'm sure you're very familiar with this. And I will mention, I don't think I have a comment on this, but one element about the state's new tiered framework is they're going to develop an equity measure, which they're still working on the details, but the goal will be that every jurisdiction will have to show improvement in the equity measure. So even if we move from purple to red or to yellow, unless the equity measure shows some improvement, we may be held back and not allowed to move forward. So most likely they're going to look at the positivity rates or the case rates, comparing vulnerable communities or maybe the Healthy Places Index or something like that, and looking at how much testing or the positivity rate that's present in those groups and comparing the highest quarter with the lowest quarter and seeing how the delta between those changes over time and trying to incentivize us so that we're focused more on communities that are more highly impacted. The state is still thinking through that and hasn't released the specifics yet, but we expect they'll provide more information on that equity measure probably sometime soon. I did want to talk a little bit about outbreaks because we not only track cases and isolate cases, but we go where the money is, and the money for containment is where the outbreaks are, because that's where things there's lack of compliance, and obviously there's a lot of cases. So this shows outbreaks over time. This is each week or each pair of weeks since here before the end of March, and we have a peak here, week 27 to 28, which is like the second and third week of July. And you can see in that week we peaked with nearly 160 new outbreaks that we diagnosed, and we've never experienced anything like this ever. I think with measles we had one outbreak, and I think it was 16, 17, and then the one that we had from Disneyland a number of years ago had a few clusters, but we've never had an outbreak, anything where we've had to deal with this many outbreaks at one time. I think we have several hundred people in our outbreak management section, and they've been very busy. This slide shows the number of outbreaks occurring in specific settings. So if you look on the left side there, the red line with the X's, these are the SNFs. And so we had a number of outbreaks we recognized back early in April. That line there was all of the testing and diagnosing those skilled nursing facility outbreaks. You can see in the darker green there, that's in correctional settings, and the little lighter green there during week 17 to 18 is other long-term care facilities. But other settings really weren't experiencing outbreaks. It really wasn't until we started to open things up in June there that you can see other settings started to experience outbreaks. So the light blue is work sites, right? We tried to open up essential work site sectors, and we were doing more testing, finally identifying some of these outbreaks that had been occurring there for a while. And you can see we had a large number of those. The red line with the squares is food facilities. So this might be, if they were restaurants or they're places where they're producing food, and a whole bunch of places like that where people are working together as another place where we had a lot of outbreaks. The point is that during the July resurgence, which affected the broader population, we did observe that the virus spread into almost every location where people were congregating and where there was a failure to comply with recommendations of distancing and face coverings, et cetera, that it was very likely that those groups would experience outbreaks. If you haven't seen the map, this was the initial tiering of the counties from the state, and you can see here is So Amanda, the colors are PROY, so that's purple is widespread as LA County. So you can see here, except for Orange County and San Diego County, virtually all of Southern California is in Tier 1, which means we're having, in general, more widespread transmission here than in some of the northern counties. You can see a couple of them are in yellow, which means minimal transmission, but they do have small numbers, and we won't focus on it. But they could have one outbreak in a cluster, and they could go from yellow to red, just because they have some of the populations are very low. And so when you're talking about cases per 100,000 and the difference between 7 and 1, one outbreak in a small county could drastically change their categorization. But here in LA County and the more populous counties in Southern California, our case rates, of course, are more stable. This slide was already discussed. Again, there's 2 main criteria. It's the adjusted case rate, which is the number of cases per 100,000. So if you think about that here in LA, where there's 10 million people, if we're trying to have a 7-day average of here, try to get below 7 per 100,000. When you multiply that by 100, that's like about 700 cases. When you have the adjustment factor that gets thrown in because we have a high testing rate, it might be something closer to 1,000 cases or something like that. And if we get below that consistently with the adjustment for a high case rate, we may eventually get that under 7 and move into the red zone. And as was already mentioned, we're already in Tier 3 or moderate for the test positivity, and we'll hear more information about that when the state relooks at the numbers again next week. And of course, I think you realize that what activities are allowed are defined by the tier that you're in. So there were some changes on the August 31st when this was announced, this new system. The state did allow some things to be open, including salons and also some other minimal things. And so again, as was mentioned, the county can be more restrictive than the state, and the city of Los Angeles can be more restrictive than the county. So in terms of our strategies, there's a lot of ways to talk about our strategies, right? You hear about a lot of the things that are going on, but I think these 3 buckets, which Dr. Ferrer has promoted, really do speak to these pretty well. Of course, we had the early 3 C's, which were crowded places, confined spaces, and close contacts, things to avoid. But we came up with these 3 C's to really define what we think are the main ways ahead to prevent the spread of coronavirus. So compliance applies both to individuals and to groups. So for individuals, this is wearing face coverings, maintaining physical distancing, avoiding gatherings, don't touch surfaces, washing your hands, and all the things on an individual hygiene level that we would expect people to do. But compliance also applies to organizations such as businesses, which it must adhere to the health officer order, and including implementing strict infection control procedures, distancing protocols, et cetera, that are required. I'm sure many of you have visited our website, and there's a long list of appendices to the health officer order that go into all these different areas and enumerate specifics of things that are not merely expected, but are required by the health officer. And so those are all the things that are needed to achieve compliance. And so, and where there have been outbreaks where we've gone in and investigated, and we find major violations in compliance consistently. We identify an outbreak as 3 cases or more. In a skilled nursing facility would be a single case. But when we go in there, if there's 5 or 10 cases or more, consistently we find that people are not adhering to social distancing, not wearing masks. They often have break rooms where people are going in together, and there's a lot of violations. And so this is a major category that we're focused on. Containment is a little bit different, and so this means really containing the spread of the virus. So where compliance is focused on behavior, containment is focused on the virus. So where is the virus? Where do we diagnose the cases? And what can we do to contain it? And as we know, certain communities are hit much harder than others. And so testing is a major tool for containment, because testing allows us to see more clearly where the virus is present, who's infected, who isn't, and helps us to be able to see where it is, and then take actions to contain it. And the only other thing I would say, obviously, collaboration and partnership is extraordinarily important. We get many complaints and many calls and are asked to go visit many places, and we just don't have the resources to go visit all of these. So we do rely a lot on partners. This is where we have our weekly calls, usually with about 6 to 8 different sectors every week. We have telebriefings. Most of these have hundreds of attendees, and we answer their questions and provide updated guidance. But mostly the purpose of that is to empower people so they're really informed about the state of what's going on, where to find information about what works, and to then implement practices in their various sectors so that they can contain this. So collaboration really is our third bucket, and we're doing all we can to work with everyone to try to contain the virus. This is an example of part of our compliance work. Our whole environmental health division, which is most of it is part of the Ops Bureau, is out all the time responding to complaints and doing investigations. They help us if we have any outbreak. Our environmental health team goes out and does an investigation within a couple of days. And in general, the purpose of the investigation is to provide people information, because even though you're all very well informed and there's a wealth of information on the web, it is amazing how many people just don't really quite have the information, or perhaps don't understand how to implement it. So often when we go in, we detect an outbreak. It really is a gap in people not knowing what is required and how to do it. So we provide that hands-on type of technical assistance. However, we do have a number of folks who won't comply for whatever reasons. And so we take a pretty hard stand on this. So if we've done all the education, we've asked for a line list, please put in plexiglass, please separate your workers, provide masks, don't have them go in the break room, have them stay distance, but queue up and get screened before they come to work. If we come back in a couple of days after we've done an initial consultation and we find that they totally have ignored things, and we are pretty aggressive in doing things. I mean, our main goal here is to protect health. So if the conditions are such that there is active transmission and there's harm occurring, then we probably would shut the group down at least temporarily, and certainly if there's non-compliance. And as you can see here, there's an escalation. We do investigate all businesses. So if they're a group that we permit, these are the first, second, third violation actions that we will take. But even if we don't normally regulate them, it's a little bit different. You can see we still have things like we would potentially shut them down. We've issued health officer orders under Dr. Davis's signature to close places, and we'd work with law enforcement and perhaps get a citation if needed. These, of course, are rare events for folks who just don't want to comply, but I do want to share that we do take this very seriously. So we're putting together the tools that we feel are needed to really protect people's health in these situations. Contact tracing, this is in the area of containment, which is one of our main strategies. I know you've heard a lot about it. And I do want to thank, the city of LA has provided us an awful lot of workers. We have over 2,500 folks in our contact tracing unit, and several hundred of those are from you. So we really are very grateful that you provided that workforce to help us. And so we have a whole, I think this electronic system where we receive the case reports and validate those, and we push that information the next day to our contact tracing unit, calling the cases, conducting an interview, getting a list of contacts, and reaching out to them. And historically, our responsiveness of folks to our case investigations and contact tracing work has been extremely poor. Even with sexually transmitted diseases, we still have an epidemic of syphilis here in LA County. Oftentimes, we might interview 10 people and might get only a handful of contacts out of the whole group. There's just a real reluctance, or sometimes they don't share the information at all. And so while our response rates for case investigations and contact tracing is not 100%, it's much better. More than half of the cases end up completing the interview and providing us information. And there's a few things we've done here. I think, about a month ago, we went to a $20 gift card if somebody just completes the interview, which means they give us some contact information and talk about their work history and where they work and some other things. We'll give them a $20 gift card. And that bumped up our responsiveness from well below 50% to over 50%. We had about a 20% increase just as a result of that $20 incentive. And then, sorry, as you know, we have the isolation and quarantine sites around the county, and we continuously have about 150 people, excuse me. For some people just don't have a home that was mentioned earlier. Without a home, you can't really do the things that are needed to protect yourself. So we have these INQ sites up different parts of the county where folks who need a place to quarantine or isolate for a few days, we can offer that to them. And then we've created this case info line as well. The idea is maybe there's some folks out there who've been diagnosed or believe they have COVID and want to connect with us as a department so they don't have to wait for the system to get the case report to come in and kind of flow through the information channel. And so we do have a case info line that stood up, and people can call in and get information, and we can initiate contact tracing and case investigation work a lot quicker. Another key area that I have found to be very helpful is working with labor. We've worked with a number of labor organizations because they hear complaints from their workers and they want to be informed and collaborate with us and make sure they're fully informed. And so, while we feel it's very important for all workers to have access to information on the requirements or what the requirements are for their employers, right, to provide a safe environment. So by working with the labor organization, we're able to get information to the workers, and then they can be more proactive where they are with that information to make sure that safe practices are being implemented. And so we've also set up a number of ways that violations can be reported to us. A number of the senior leaders in these labor organizations are sending us emails. We have an email, and we also have a number that workers can complain or call and just let us know about their concerns, and we will respond to those and conduct investigations. And you can see our public health councils here that we've recently set up and trying to build better information flow so that people are informed and we can respond to any concerns or issues. I assume most of you have at some point visited our website. I'm not going to go over this in detail, but there's a wealth of information here that includes not only all of our data, but it also includes health officer orders and all the protocols that we ask people to follow. I'm going to just answer a few questions, then I'll open up for your questions. One of the questions that I was asked was, what evidence is there of the effectiveness of the strategies? It's somewhat ecologic to make these inferences. We don't really look at it on the individual case level, but at least from my point of view, I've been very impressed with just the general original Safer at Home order, the openings and how that pulled back, and just the trends themselves show how remarkably effective that was, or the impact that has had. Of course, the trade-off has been people at home or in isolation. It's not a good strategy. So in the long term, but just the simple practices. We do review the science every day. We have a librarian here who every day is scanning the medical literature, and every day I get a feed of about 10 articles that are new. And so we have a number of us at any time looking at those. And again, there's a lot of studies really showing that even if you simply had universal wearing of face coverings, that simple intervention alone would have an extraordinary impact. And there are studies that show that, et cetera. So we do look at that and apply what's being learned as we go along. The question has come up is how effective were our previous plans? I think what we've all learned is that a lot of assumptions made early were incorrect, right? Our early strategy was airport containment. And, you know, while we were trying to interview people coming in through the airports, the virus was coming in already to the country and other parts. So, you know, that whole airport containment strategy, I think we identified one infected traveler. And meanwhile, a lot of disease had already come into the US. There were early assumptions that people who are asymptomatic didn't spread the disease. We know that that's been found to be wrong. There were things about children and, you know, what's their infectiousness, et cetera. More recently, there's been a lot of light shed on that. There was a morbidity and mortality weekly report out of 3 child care facilities in Utah just published last Friday that showed a small cohort of children, spread it to one another, spread it to adults, and one of them was hospitalized, et cetera. So our learning is continuing to evolve here, that even very young children are infectious and pose risk of transmitting this virus. So there was a lot of things early on and plans that we made that weren't very effective because our assumptions were incorrect, basically because our knowledge was very limited about this virus. There were some good questions already asked. I think, Dr. Mendel, you mentioned these already. Are there ways we can look at this data differently? And I know we spoke with Mayor Garcetti a few weeks ago, and he's got the same kinds of questions about our data. And we're very interested in trying to figure out how to answer these questions for you. And so it's true, as mentioned, you know, rates are adjusted. The incarcerated individuals are removed from the data set, and sometimes there's some data sets remove people from some of the long-term care facilities, so we can really look more at the the transmission that's going on in communities. But I think there's a lot more that we could do there, and there's a lot of opportunities. Some of this other suggestions here showing outcome data by BMI or narrower age categories, you know, I think that's a good idea and it's all doable. And as was mentioned before, some of the data is already broken down by political districts, et cetera, but there's probably more that could be done. My suggestion there is, I'm not sure what the best way is to do it, but if we could sort of get a prioritized list of like, here's the top 5 questions that we have. We're having a very active dialogue about this because we do want to answer questions for the city, and you would be a major proponent in help defining what is most of interest to LA City. So we'd be glad to receive those requests and try to complete those analyses. And then for the last question, what opportunities are there to improve communications? I'm open to anything that you might suggest. I'm not sure who from our department has spoken with you all before. Paul Simon, who's our Chief Science Officer, is in regular communication with LA City. I know he's working with the governor and his staff are regularly attending meetings. But between Paul and me, there should be ways that we could increase our communication with you in particular. And I'd be glad to hear your suggestions and figure out a couple of strategies that would be more helpful to you. So with that, I think those are just a few answers to a few of the questions that were sent my way, but I'll open it up to more general questions that you may have.
Thank you. That was a wonderful presentation. I truly appreciate it. So following up on some of your slides, when you pulled out the short-term nursing facilities, the SNFs, is the assisted living and the nursing homes are separate legally from definition from a SNF.
That's right.
So is the data for SNFs only SNFs?
That's correct. Yeah,
Okay.
when we show those SNF desks, there's close to 400 SNFs in the county. A number of them are affiliated directly with, they're integrated into hospitals. So there's a little over 300, maybe 320 or 330 that are freestanding SNFs. And those aren't the nursing homes or the assisted living. Those are different facilities. So we're talking about SNFs. We're talking about the skilled nursing facility subset.
Right. So because clearly those other two groups are also highly infectious, have known for a long time to be little petri dishes for spreading infectious disease. It'd be important to see that numbers and take that number also out when we're doing our adjusted numbers, because that's going to be a very high percentage of individuals who unfortunately will become infected and end up hospitalization given their age and or their chronic diseases that put them in assisted living and or in a nursing home. The other group that is interesting is we talk about pulling out the incarcerated individuals, but because of COVID and for other reasons, we've let a lot of people who were incarcerated back out into the community. And those individuals go back to their homes or go back to their families. And so theoretically, they were a very high risk exposure situation. Now they can theoretically spread. Is anybody tracking those individuals to see if they've actually caused bumps in the infectivity in their local communities?
Yeah, it's a good question. I know we struggled here in LA to try to figure out how to release folks so that they weren't infectious, but in the end, it was like you said, there were folks who were released who we really couldn't track. We were focusing for quite a while in terms of our investigative work on the high risk facilities, right? We really focused on the SNFs. It drew so many resources when we realized that was a challenge. And it took us a little while to expand our case investigations to ask questions like, where were you before? We now are asking those kinds of questions. We've been doing that for about a month. So if somebody had been incarcerated or something like that, we can pull that data out. I'll check on that, but to the best of my knowledge, I'm not aware of clusters that have been initiated, but from folks who came out of from a situation where maybe they were in the jail and now released home. But I'm going to double check on that because I agree with you. It would make sense. There should have been some clusters resulting from that.
And it would also be important not just for us to know for the future, but also from an academic point of view, that would be publishable information that would help the whole entire country.
Totally.
The last question I have before we go to other commissioners is in the color-coded data, there's arbitrary numbers of 7 per 100,000 and 4 to 7 per 100,000. How are those numbers picked?
I don't think I know. I wish I did. They probably looked at the range. I mean, one way to set goals is look at the existing distribution. And if you said, okay, we have so many counties here and we want them all to improve, they may have picked points in that way. 1 per 100,000 is a pretty low threshold, right? A lot of counties don't even have that many people. So if they have one case, they're over the threshold. So for many counties, it means no cases. Here in LA County, 1 per 100,000 would be 100 cases, which would be very, very low. So to me, that cognitively, it does resonate with the idea of minimal transmission, right? So when I look at it, if we get to 1,000, that's kind of where we've been. When we started, we thought if we get over 1,000, that's really widespread out of control. So when you're looking at the 7 per 100,000, intuitively to me, that does sort of resonate with, based on our experience, yeah, that is widespread transmission. So I'm not sure exactly how they came up to the numbers. I don't know if it was because they looked at data or they kind of went through it intuitively, like I just said. But they do sort of fit with my view of the breaks between those categories.
Okay, but they appear to be somewhat arbitrary in that we've made major economic decisions based upon those numbers, or we are still making major economic decisions based on some of those numbers. And when we look at the data comparing LA County or LA City, the second largest city in America, versus all the boroughs of New York, we're doing much, much better than those different boroughs or communities or counties. And yet, we're closed down and they're open up and their numbers are still worse than ours.
It's a good point.
Great, moving on. You could close, I think, your presentation area so that we can see your face again. Otherwise, right now you're...
Thank you for reminding me of that.
Thank you. Commissioner Cato, you have a couple questions.
Yes, thank you. Thank you so much, Dr. Geisenhower, for the presentation. Okay, one of the questions is, I'm really happy to hear that we're trending down, and it must be a greater assimilation of those 3 C's that you were talking about. But also, how are we as far as the supply of PPEs? Do you feel comfortable with what's available to our healthcare workers, to all the facilities, to the schools that may be opening up? And are we ready, if there is a surge, to have it available to meet any increased needs? That's my first question.
No, that's a really good question. I think for the healthcare community, the availability has greatly increased and improved. We have several different teams working on this. For the healthcare side, EMS is the lead. And so they have regular tracking with all the healthcare facilities of their status, asking them to report out. Do you have a 2-week supply? Or are you less than a week? Is it 3 days, or where are you? So the charts that I have seen have shown that the supply has increased dramatically there. We work to support the non-healthcare facilities. So all those other facilities, long-term care, adult living facilities, et cetera. We work with them. We have a similar way of querying them and finding out who has PPE. And then we've pulled every plug we can, either to purchase it or to get a shipment through whatever channel we can. And the ones that have had the most need, we provided to them. Based on the charts that I've seen, we've done pretty well as well in that category. But your point is well made. There's some good publications out there that look at, could procedure or surgical masks be used in other situations? The World Health Organization put out a report that probably high-risk individuals should wear those. They do, a cloth covering is for source control, but if you're a high-risk individual, what you want to do is prevent getting infected. So you really need a mask so that if you inhale it, will absorb some of the virus. So there are some reports out there that folks at high risk maybe should wear a surgical or procedure mask. And there's 1 million folks over the age of 65 in LA County, so that's a lot of masks, a lot of surgical masks to do it. And you're right, in schools, it will be interesting to sort of see how they evolve. And we're talking about that now. What are the requirements, and how can we even do that? But there's an evolving literature that some face coverings are better than others. I'm sure many of you have looked at them. If you've got 3 pieces of material and it's designed a certain way and it covers a certain face, it's going to be more effective for source control and probably for individual protection. But we haven't quite translated that evolving knowledge into active practice, so we have assurance that some of the face coverings that are being used are as effective as they could be. So I think we're going to learn a lot more about that as we move ahead.
Okay, thank you. And my second question is on your slide number 9. You had the Los Angeles County total of case rates. You have Latinos as the second highest ethnicity group. But here in Amanda's the city data COVID chart, the percentage of county deaths by ethnicities, Latinos were the lowest at 0.3%. Can you explain that?
Well, yeah, I'm starting to think of various Venn diagrams right now, trying to reconcile those numbers you gave me. But it could, the relative frequency distribution by, or the rate by, I'm trying to think through this, because what you said was that 0.3% of I think what you said among Latinx in El County, 0.3% of the mortality occurred in that group. So that might be more like the mortality rate. And I don't know how that rate compares. I'd have to look at the city data to see what the comparable rates are in the other race ethnicity groups. And you're saying that's low or high?
Right. Well, the Black African Americans is 37.4, others is 37.1, white is 11, and we keep going down. And the lowest ethnicity group is Latino Hispanic at 0.3, and yet the case rate is the highest, second highest for Latinos.
I'm sorry, I can't. I have to look at that to see what the reason might be. Do you have an idea, Amanda, why that is that way?
I was actually just going to ask what you're looking at, only so that I know and can track back to which slide, because Latino and Hispanic have traditionally been the highest. On slide 37 of what will be today's published document, I'm not sure if it's gone up yet, but I believe it's slide 37. You'll see that all of the everybody's coming down, but Latino still remains the highest at, I believe, 8.7%. I'll have to find out what slide you're looking at.
Okay, but okay, it's the LA mayors, and then where you were looking at the data, it's the chart that's right above where it says summaries of data related to COVID-19 response. It's the last chart right above the summaries.
Okay, I'll take a look at that. Thank you.
Yeah, it's the first link you sent on the website on the dashboard on the bottom.
Okay,
it breaks
take
it down.
a look.
There's 80 pages of data, so there's possibility that somebody typed one number off, and it is, you know, we'll look at Commissioner Nakata.
I see what you're saying.
Yeah, we can always get you the information.
Yes, thank you. I'll follow up on this. I can't actually answer why that says that right off the top of my mind, but it should be actually more aligned with what's in the doc. So that may be actually just a dashboard error, which sometimes actually happens. We do a lot of review on the dashboards to be sure that doesn't happen. But in the deck, I'll just pull it up real quick so I can direct you to which slide it is. And in the meantime, I'll actually follow up on the dashboard matter. So thanks for pointing that out.
Okay, thank you very much to the two of you for taking time out tonight with us.
Pleasure, thank you.
Commissioner Shannon, you have a question.
Yeah, so I had an issue with a woman that I was helping who was in a nursing home, and she actually had COVID, and the nursing home, because her insurance ran out during the time that she had COVID, she had to make this decision between staying in the nursing home and paying whatever that daily rate was, or leaving, because she was only there, she was recuperating from surgery. So what protocols, this was a couple of months ago, so I'm just wondering, like, what protocols do we have in place to protect seniors who are in nursing homes from having to potentially leave if their insurance runs out?
Yeah, that's a really difficult issue. I'm not sure I have a good answer for that. You know, I am very aware that this is a critical issue. I've heard it in the news. We do try to help make transitions. If people move between facilities or move from a facility to home, how could we help them so that they're safe? But in terms of the protections for, you know, protecting them so that they continue to receive those safe services there, I don't really have a good answer on that one, Susie, Shannon, and I'll look into that and maybe get back to you to see what I can find out.
Okay, yeah, thanks. I mean, because it's problematic, because if they're moved to home, they have to be taken care of by a caregiver.
Yeah.
And the problem then is that, you know, if they have COVID, then they are exposing, I mean, actually in reality, they probably wouldn't find a caregiver who could help them if they had COVID.
Yeah, that's a huge problem.
That might be a federal issue, in that most of those people, not all, but most of those people are going to fall into a category of above 65 and or some, you know, chronic disability. I'm wondering if the county could discuss with CMS, because they do have, you know, the rules on the number of days you can be in one facility or another facility is all CMS based. That might be a place for Administrator Varmer to make a ruling, temporary during this point of pandemic, not just for our county, but nationwide, that individuals who are already being well taken care of in either a skilled nursing facility, SNF, or a nursing home, with being paid for by the Medicare system, that gets extended temporarily, you know, in this time of emergency, because if it's happening here, it's got to be happening elsewhere in the country.
Yep.
So I'm not sure who would be the person. I mean, obviously the county has a liaison with CMS. That'd probably be the best person to maybe, you know, present it. Or if not, the Board of Supervisors potentially could go directly, or our members of Congress would potentially be another choice.
Yeah, I've got a number of folks I can check with quickly to find out what protections there are, and state contacts as well. So I think I can find out. I'll find out the state of that and share that information back with you. But I think you're right. If it looked like, that would be something that the board or the state could take some advocacy around, and as you're saying, the administrator could make a ruling to solve that problem, at least for the short term, which is a good idea.
Yeah, it would prevent spread elsewhere in the county, which would be a good thing for everybody. It would lower our numbers. It would also give better care to that individual, because even if we sent them to their home, they're more likely not going to have the protective equipment. So they're more likely to spread to their family members or their neighbors. And they're already being well taken care of. So just to extend it would cost the government much less than getting one person infected and bouncing them into a hospital.
Yeah, great.
It's cost effective. Any other commissioners with a question? Seeing none, I'm going to thank you, Dr. Gunzhauser and CIO Daflos, for coming and presenting to us today. We truly appreciate it. We look forward to working with you going forward. We truly appreciate you educating us and your service to the people of the city and the county of Los Angeles. You guys can sign off now. We have a minimal amount of business left for our meeting, but we truly appreciate you coming tonight and giving of your time.
Okay, thank you very much. Pleasure.
Thank you, everyone. Take care. Bye-bye.
So, Rita, has anybody else, any other commissioner signed in so we could have a quorum or not?
We had Commissioner Hisarek join us, but that brings us at 6 members present. We need 7 for a quorum.
So nobody else called in. Okay. So I'm seeing that. Then we can't handle the prior minutes. And can we adjourn, or how's that work without a quorum?
Do you want to do the items for future discussion? And then I guess we just end it after that.
Yeah, I think we have several other items for future discussion that have been bouncing around. I would just say to all the commissioners, you can send the interns ideas you have. We'll work them through and try to get everybody's concerns addressed. We're open to everything. And these last several months, I think we had some excellent presentations with experts that really help us all, and we're willing to do more. So I think we're open. It's not like we have too many demands for the next couple months.
Sounds good.
Can I make a suggestion?
Please.
Can we get someone from LAUSD to get an update on how they're preparing for in-person or hybrid?
We can try. We've tried before, but we can try again.
Try again.
We also tried to get the Office of State Health Planning, OSHPD. We've tried to get them for, I don't know, 2 years now, and have not been very successful. But it's interesting to know that somehow the city and the county are getting up-to-date hospital data, which is really why we wanted to get the numbers. So what we need to do is independently get that data sent to us, or get access so that we can click on directly, so we can make sure we know the number of hospitalizations to make plans. Any other ideas or thoughts? Can I ask for a motion for adjournment then?
I make a motion to adjourn.
Second.
All in favor?
Aye.
Aye.
I'm seeing no opposed. Brock, is that within city rules that even though we don't have a quorum, that everybody here is willing to adjourn, that it's unanimous that we can adjourn?
Yeah, yes, President Mandel, you don't have to keep the commission in for the next month. So yes.
And perpetual attendance.
Correct.
That's right.
You know, sort of like the Senate, you can't adjourn technically because you're worried about another party doing something. So you always have to have it. No, you don't have to have that here. You're good.
And then to the general community, if the general community is out there, to any individual who is celebrating the Jewish New Year, L'Shana Tova, may you have health and happiness and be written in the book of life and prosperity. Thank you, everybody, for attending tonight. The meeting's adjourned.
Thank you.